So we're a small group, but I think we can start. Dear ladies and gentlemen, dear colleagues, we have a little bit delay from the main arena, so I hope that more people will join us in the next minutes. But I think in order to catch our buses to the dinner, we can start. I'm very happy to chair this session, Simplify Your Most Complex and Calcified PCI, with my colleagues here, moderator Mr. Tommaso Piva from Ancona, and two experienced operators, PCA operators, and also in complex PCI cases, very experienced, Andi Mucaj, also from Ancona, and Christoph Pujak from Herford, Germany. So, we have to say the complex PCIs and especially the CTOs are very specific fields, and in the last 20, 30 years we had a monopoly, more or less, with the rotablation. In the 80s of 90, the cases with rotablation reduced, and we experienced a renaissance in the 21, 22, with much more cases of rotablation, of orbital atherectomy. But in the last 2 or 3 years, we have new players in the game. We have the lithotripsy, and since 6 months, we have the orbital atherectomy, especially in Europe. That changed everything, I think, Tommaso, in the field of interventional cardiology and in the field of complex PCI. But I think we can see that in practice from our presenters with interesting cases. That's why I will invite Mr. Mucaj to present the cases he's already prepared. Simplify complex PCIs.
Thank you. Thank you, the organizers, for inviting me. Good afternoon, everybody. So the topic of my presentation is how to simplify our most complex and calcified PCI. I'm trying to give some answers with 2 case reports from interventional lab at Ancona Hospital. I have no conflict of interest. The first case is a 73-year-old male with hypertension, dyslipidemia, ex-smokers, familiarity with coronary artery disease. He had a history of kidney transplantation in 1988 and later renal impairment with actually dialytic therapy. He had paroxysmal aortic fibrillation with actually warfarin treatment since 2010, previous TAE, peripheral artery disease, and he experienced ischemic stroke and hemorrhagic stroke respectively in 2019 and 17. The patient was brought to our attention by the colleagues of the nephrology because not for mild dyspnea, but because they revealed a very high BNP level, and routine echocardiography demonstrated a severe dilatation of left ventricle with severe left ventricle dysfunction, a very low ejection fraction, with smoking affect the apex, also akinesia of the inferior wall with hypokinesia of anterior and septal wall, a severe dilatation of mitral annulus and severe mitral regurgitation, also associated with right ventricle dysfunction and moderate tricuspid regurgitation with elevated SPAP. So he presented, Okay, this is the angiography, elective angiography. You can notice chronic total occlusion of right coronary artery, and there is a very tight, calcified lesion in the proximal LAD. We discussed the patient in the heart team to decide the strategy, and thanks to the multi-comorbidity and the high STS score, we decided for angioplasty. And plan the procedure, we choose 7 French right femoral artery with 7 French guide catheter. The patient has a very low ejection fraction, but so we plan to support the procedure with the intra-aortic balloon pump and plan to use a diamond-back orbital atherectomy system, a new alternative of atherectomy. Also the CTO devices. We decided to prove this new approach that, differently from the traditional one, is based on a 1.25 crown mounted eccentrically that can treat vessels up to 4 millimeters, and creating some centrifugal forces can send and fracture the calcium with pulsative forces. And the characteristics are that it's bidirectional, it's a different way of fractioning, and allows continuous flow of blood and saline during the spinning. So we implanted intra-aortic balloon by left femoral access, and this is the first injection with 7 French guide catheter. You can appreciate even more severe stenosis of the proximal LAD with severe calcification, very eccentric. And we started with the orbital atherectomy system. The wire was advanced in the distal LAD without the support of microcatheter, and it was easy. And we started to spin with 80,000 RPM. First spin, second, first anterograde, second one retrograde, third one, and the fourth one. And we obtained this angiography. You can see the difference in the lesion. It's the reduction of calcium burden at the lesion. But we couldn't perform IVUS yet, so we start ballooning with 2.5 NC balloon at high atmosphere, different times, and we could perform finally an IVUS. And the IVUS showed what we expected, a calcified lesion, circular for long length of very deep calcium. And after the IVUS, we noticed also some tears in the calcified cap of the lesion, probably not only by the balloon, but also by the atherectomy system. We went on with other balloon, 320 NC balloon and 3.520 NC balloon. And we obtained dilation of the lesion. This is the first angiogram after ballooning on 3.5. There is a localized dissection, but at this point we decided to implant drug-eluting stent. So by the support of 6 French guide wire, we advanced 3.538 Newton drug-eluting stent and implanted successfully, and was dilated with another 3.520 millimeter balloon at high atmosphere to have a good dilatation of the device. This is the final result. You can notice the cranial left and right, and also the caudal view, with a good expansion of the stent in the proximal LAD. This is also final IVUS. Then there is no signs of malposition. It's a good accepted expansion of the stent. Nevertheless, the lesion was severely calcified. The patient did well during the period in the hospital. No events since the discharge. He had an improvement of the left ventricle function, raised to 30%. The mitral regurgitation turned moderate, and that was a lower SPAP. And at the end, the patient implanted CITDD, and we waiting him for control the next month. This is the second case. We're going to make the discussion at the end of both cases. This was a 67-year-old male affected by hypertension, dyslipidemia, ex-smokers. He previously performed PTCA on the proximal AD for stable angina. No symptoms, normal left and right ventricle function. In routinary stress test during May, he has a myocardial-induced ischemia, and CT scan confirmed stenosis, severe stenosis of the right coronary artery. And that was confirmed by the base angiogram. The left coronary artery has no stenosis, but the right coronary artery, we noticed severe calcified stenosis with irregular board in the mid portion of the right coronary artery, a significant one in the third segment, also a severe one in the circ, interesting both branches of the bifurcation. We planned, it was more easy, there are no doubts about the indication. We choose to use a right radial artery and 6 French guide catheter using again Diamondback, OAS, and also the CTO devices. And this time, the wire, Viper wire, was advanced with facility in the distal segment, and we performed several spins with 80,000 RPM that could overpass the severe stenosis in the mid portion and arrived almost going anterograde and retrograde, arriving almost in the crux bifurcation. This is the third one, another one, and the more distal one was that angiogram that arrived approximated to the bifurcation. We tried to make, this is the angiography after the treatment with Diamondback. We tried to perform an IVUS. The IVUS couldn't pass the lesion, but we noticed the severity calcification in the mid portion of the right coronary artery. So went ahead with bone. This was a 2.2515 bone. We used Sapphire 3 1.2510 to cross the distal lesion, and after some times we succeeded to cross the bifurcation. And we boned with other NC bones in the distal part of the right coronary artery. So finally, we could perform an IVUS. This is the pullback from the distal artery to the proximal. We can see severe calcification in series, distal segment, and also in the mid portion of the segment. So went again with treating these lesions. The posterior artery was treated with drug-eluting balloon, and we implanted a drug-eluting stent in the crux. We succeed, and later we tried to treat the other lesions in the mid portion of the right coronary artery and the distal portion. First with Sapphire NC24, 322, 3.515, and 418. And after that, we see a good expansion of the balloon, so decided to implant 433 drug-eluting stent in the mid portion, and also in our position another 3.5 18 millimeters drug-eluting stent in the mid distal portion, and post-dilated with NC24 Sapphire 4.5 15 millimeters with a good expansion. This is the final result of the right coronary artery after the post-optimization. And the IVUS confirmed a good expansion of the devices in all the segments treated with stent. So which are the messages that I can give by these two case reports? To perform successfully a PCI, The first important step is going to be the lesion access, and in very tight calcified and tortuous lesions, a good crossing profile balloon is necessary, and in our case, the Sapphire 3 was a good choice for crossing this lesion in distal vessel. This is a flow chart, a schematic flow chart that we use for calcified lesion, and we can see that the atherectomy in the mild to moderate calcification is in the end, while in the heavy severe calcification or in crossable lesion, the atherectomy device, we can start with atherectomy device. And the other question that every time we used to make in very critical situation is, which is the right weapon that we have to break the rock? It depends who breaks, it depends on the rock, but also it depends on the contest that we have at home. These are actually alternative. There are different weapons, some older and some newer. But in this case, this new alternative for the treatment of cervical calcified lesions like diamond back or orbital atherectomy system was simple, efficient, and safe. Of course, this is very beginning, so we need other data, our experience, but the first results were promising, and combination therapy with also between this device and the other one are possible. And the post-optimization therapy also was very efficient with NC Sapphire 24. So I would conclude saying that in dealing with complex cases with calcification, it's important to have the right CTO toolbox for lesion access, lesion preparation, and lesion therapy. And optimizing the stent deployment with NC balloon and the second level imaging is needed to have good clinical outcome. Thank you for your attention.
Andi, thank you very much for your cases. A great job, well-treated calcified lesions, very tough lesions, but as I say, well-treated. Are there some questions from the auditorium? So, also from the panel? I have some questions. I'm very curious. Actually, we are, as I say, in Europe, in a new field with the orbital atherectomy. Why you choose orbital atherectomy to treat this lesion? Why not rotablation? Why not lithotripsy or directly balloon dilatation with high pressure balloon, for example? What was your thought to go directly to orbital atherectomy? What was the benefit?
So I excluded to go directly with NC balloon because they are very severe calcification. By my experience, when I see that calcium, I try to choose rotablator or larger or shockwave, but it will be hard to overpass the stenosis because it was very tight. But this is that kind of lesion that if I have the possibility, I start with something different, or laser or atherectomy, and we didn't have this new approach. It's approved since 7-8 years in the US, but it comes in Europe in the last months, and I thought that it was it was my first case with diamond back, so it was the right case to start.
Mm-hmm. Okay.
But I have several times I have treated these kind of lesions with laser or less frequently with rotablator, and when I started with the balloon and upgrade, I don't like it anymore. So when there is severe calcification, if you feel comfortable, you have just to prove. Okay. The first patient also was a patient with warfarin therapy, and maybe the alternative was laser, but I'm not sure whether I would have proved with rotablator because I was able. Yeah,
I think that as it is a truly intimate session, we can. To be honest, we can say that we were curious
about
how it works. Yeah, atherectomy.
So we have to start. I think that
it's
the
one
patient.
Of the reason. Yeah. The other is that we know from studies and from OCT studies that the lesion preparation with orbital atherectomy is much more effective than with other techniques. So I think that we And the third is that in our thought, in our belief, is it is a safe procedure. And even it is so safe that even in an unexpert hands, it can be done quite easily. I mean, of course, one has to be careful when manipulates coronary arteries in every way, but especially when the bulking is needed. And it seems to be very safe tool.
You said already that you use laser or heart ablation.
Yeah.
What is, so to say, your experience after a few cases with orbital atherectomy, especially in comparison with the rotational atherectomy? Do you mention some special issues, especially the hemodynamical compromission? In the first case, we have a patient with 20% LVF.
I didn't see any compromission of the hemodynamic. The patient was always stable, and we implanted intra-aortic balloon, but after the procedure we put it off, and he had no.
No catecholamines, no.
No, nothing. No.
Okay.
In this case, no.
Okay.
In the second case was more easy because the ejection fraction was normal, but the first case, CTO of the right coronary artery and severe lesion.
Indeed, I would also go for the RIVA, for the LAD, as you did actually.
Yeah. And, I was afraid to use a rotablator because it was the patient was very delicate, and warfarin therapy. Maybe if I didn't have the orbital atherectomy, I would have used laser. That needs more time to achieve the same goal, but is more safe. And in that patients, maybe, so you have not to change the wire. And in this case, we used the Viper wire. But if you want to make
directly.
rota, directly. In the first and the second case, or both cases. Yeah,
Without
it was
exchange with a microcatheter, directly?
no, directly. Okay. And we started and finished the procedure by that wire. In using rotablator, in that case, you have to spend some time, and that patient is. At the very beginning we saw a dissection. We implanted the stent. I don't know how it would be with the rotablator. So we thought it was better to use orbital atherectomy.
It's very interesting that you didn't use a microcatheter in the second case. In the first case, we have enough lumen to go with...
Yeah, but in the second case, the wire advanced it a little bit more difficult because the stenosis was calcified, but with irregular boards. But at the end, it arrived in the end and worked. Okay. And this is a very good point, because if the first and the second case that you make with atherectomy, you don't use a microcatheter, it means that there is a good possibility that in the future most of the cases you are going to make without. Not always, but we have to learn experience. It is starting.
Indeed, also in Europe, not American colleague. And another question I have is about the AV block. So we are used to put a pacemaker, temporary pacemaker, especially if we rotablate, if we make a rotational atherectomy in the right coronary artery. Your second case was a right coronary artery atherectomy, but I didn't mention any pacemaker.
No, we didn't put the pacemaker. I just put the sheath, the access. So the ejection fraction was normal, and I didn't put the pacemaker. Maybe it will be more safe to. Okay. Sometimes I do this, but this was a symptomatic patient, normal ejection fraction, so I just insert the sheath, but not the pacemaker.
Okay, and did you mention any arrhythmological problems during the procedure? No. So completely stable?
Yeah.
Hemodynamically and
hemodynamically, and no problems with heart rhythm, and it was very good experience.
Nice, very nice.
Very nice.
Also,
surprising.
Results. Surprising, indeed. For the first experience in Europe, I have to say, 2 tough lesions, very calcified, and good selection of patients, and well-treated results. Very good. Thank you very much.
Thank you.
I think you have to continue with our next presenter and speaker, Mr. Mucaj from Hereford, also a very experienced CTO presenters, and we will focus on non-CTO chip procedures. Christopher, please.
Yeah, thank you very much for your invitation. Thank you for having me here. I will give you a small presentation on how to improve some non-CTO chip cases using CTO mindset and CTO techniques. First, we have to think about what is a CTO mindset. I was thinking for a few minutes about that, and I think that's all about being prepared for changing conditions. It's about knowing how to treat possible complications. It's about not relying on miracles and knowing devices and techniques we use. And all of this can enable us to make complex cases as easy as possible. Proving that, I will show you 3 cases from last 3 months, which can illustrate these principles. So the first case I would like to present you is a young patient. At 2018, he was 42 years old. His risk factors are obesity, his arterial hypertension and dyslipidemia. On echo, he had a good left ventricular function and no other relevant comorbidity. And based on positive non-invasive stress test, a coronary angiography was performed in outside hospital. And this is the angio. As you can see here, there is a severe ostial stenosis of the right coronary artery. A shot in the left, shot in the left coronary artery shows also some severe disease in the left main stem. And as you can appreciate on these images, there is no relevant disease of the peripheral vessels. So only the ostia of both right and left coronary arteries are affected. The patient was directly referred to cardiac surgery for coronary artery bypass grafting at that time. 2021 was this year. The patient has been admitted to our institution because of class 3 angina, shortness of breath, and peripheral edema. He had ejection fraction of 30 to 35%, and the angiography showed patent Lima graft. But as you can see here, this Lima graft is attached to a very distal portion of the LAD. And there is also a stenosis of the LAD proximal to the anastomosis. The right coronary artery is still narrowed, similarly to the result of the coronary angiography performed back in 2018. So there is no relevant difference to this result. And the sequential venous graft, which was supposed to support the circumflex artery and right coronary artery, is partially functional as well, because the graft to the marginal branch is occluded and the distal vessel the bypass graft is attached to is very small. And the shot in the left coronary artery shows now an occlusion of the left main coronary artery. So really disastrous result in a 45-year-old patient. So what was the plan? So we decided to go for impella support due to severe left ventricular impairment, and then proceed with the multi-vessel PCI to the RCA and left main. So the IVUS evaluation of the right coronary artery showed some modest calcium burden of the ostium, some negative remodeling, but it was not necessary to go for atherectomy in this case. So the vessel has been predilated with some balloons, non-compliant. Then a Boston Synergy Megatron stent was implanted. Then it was post-dilated with Sapphire 5.0 balloon, and we achieved a nice MSA of nearly 20 square millimeters. As you can see here, after improving the flow in the right coronary artery, there is still no visible collateralization which could be taken into account for retrograde recanalization. Only this very tortuous epicardial collateral, which is not suitable for an intervention, in my opinion. So we proceeded with antegrade recanalization of the left main, which was indeed quite easy and fast. So the Gaia second wire could pass easily the lesion. This is the tip injection over a microcatheter. And then the wire has been exchanged to run through extra floppy. After dilation with Sapphire 1.0 balloon, the circumflex could be negotiated with a whisper wire, but no full balloon expansion could be achieved. So we exchanged the wire to a Viper wire, and then we performed orbital atherectomy of the left main and LAD and proximal circumflex. And the flow could be definitely improved. Then after the orbital atherectomy, good balloon expansion could be achieved with nominal pressures. And the final result after stenting the left main with Megatron stent and circumflex and LAD with supraflex DES could be achieved. And the further course of the patient was very good as so far. The second patient I would like
Christoph, a quick question.
Yeah.
Do you perform the orbital atherectomy from the left main to the LAD and then from the left main to the CX? So
Correct.
both vessels, okay.
Both vessel, everything. Yeah, I will show you some other example here. 77-year-old female patient with diabetes, chronic kidney disease, complaining of typical angina, and she also had severely impaired LV function with ejection fraction of 25%. So as you can see here, she has severely diseased, very tortuous LAD, and there is severe calcium on IVUS, and what we planned here is to treat the LAD with orbital atherectomy. And what I would like to highlight here on this panel is that the Viper wire, which is really very, very workhorse-like, could be negotiated to the distal segment of the LAD without any problems. So it was not necessary to exchange the Viper wire over a microcatheter. Then the orbital atherectomy could be performed without any hemodynamic compromise. And this could be, in my opinion, contributed to the fact that orbital atherectomy creates very small particles, which are smaller than, for instance, in rotational atherectomy. And then the risk of vascular bed overload can be minimized, which is very important and very crucial, especially in patients with this kind of severely impaired left ventricle, like this lady. So, and then as you can see here on the left panel, the Viper wire could be nicely redirected from the left, from the LAD into the diagonal branch, and then a second run or some runs of the diagonal could be performed. And the result after stenting was quite nice. We treated the LAD with stents, the intermediate branch also with stent and some drug-coated balloons. Also for other osteal disease of the smaller branches, and the further course of the patient was very nice, very good. The last patient I would like to show you in this session is a 75-year-old male with type 2 diabetes and class 3 angina, and this patient got an angio which revealed severely calcified left main stem with eccentric plaque protruding into the left main stem and blocking access to the LAD. So wiring the LAD with whisper light support wire, which was my first choice at that time, and with standard microcatheter support was not possible. Enhancer double lumen microcatheter and whisper light support and SUO 03 wire were unfortunately unsuccessful either. Here you can see on the right panel the double lumen catheter and SUO 03 wire, which gets stuck in the plaque every time I tried it to advance it into LAD. Then we decided to wire the circumflex artery with Viper wire and perform the orbital atherectomy with high speed to modify and reduce the plaque protruding into the LAD ostium. Unfortunately, reattempts to wire the LAD with SUO 03 and enhancer double lumen microcatheter were still unsuccessful. And as a last resort, I inflated the blocker balloon on the circumflex wire to redirect the wire, the other wire into the LAD, but it didn't work either. So 2 days later, after I have ordered the angle tip microcatheter, the job could be done within 5 minutes or 2 minutes. So the wire could be redirected into the LAD. And then, after some pre-dilatations with small sapphire balloons, wiring the LAD was without any big efforts. So was done without any big problems. Then the wires have been exchanged for Viper wire, and then low and high speed orbital atherectomy was performed. And then we stented the left main towards LAD and later left main towards circumflex as indicated in culotte technique. And then in preparation, I skipped some steps for the sake of time. After some steps in preparation for the final kissing balloon inflation, I crossed 2 stents with 1 single balloon. The first stent I have crossed was the stent from the left main towards circumflex artery, and the balloon entered into the LAD. And then the second stent which has been crossed by this single balloon was the LAD stent, and it went without any problems into the diagonal branch. So it shows nicely the low profile of this device. And after this final kissing and potting, and a nice final result could be obtained. And as a summary and maybe some take-home messages, I would like to highlight that similarly to CTOs, other chip PCIs can stretch capacity limits of both interventional devices and interventionalists. And complete toolbox is crucial to achieve constantly good results with low complication risk and acceptable procedural time. And orbital atherectomy is a very valuable tool for many chip PCIs, enable utilization of 6-French guiding irrespective to the diameter of the vessel to be treated, with workhorse-like performance and low risk or no flow phenomenon, even in very long, highly calcified lesions. And as the last point, I would like to make the low-profile balloons are critical, not only in CTO PCIs, but in many complex two-stent bifurcations. Thank you very much for your attention.
Christoph, thank you very much. Really tough cases, great job in all three cases with very complex bifurcations, very calcified lesions. Of course, we can discuss about the indication, why CABG in the first case or why not CABG in the last case, but I think we focus especially in the interventional issues in order to learn something about this special technique, the orbital atherectomy. So are there any questions from the auditorium or from the panel?
No, I have 4 questions, or at least I found 4 points that have been surprising for me. The first one, let's say, is how well works and responds the Viper wire, which can be easily maneuvered and directed into side branches. And second point is, once more, we didn't observe any hemodynamic turbulence. And would you use again an impella for such lesions? Or the third point is the one that surprised me more, is that after an ablation of the left main, you could wait 2 days with no events, and you could fix the lesion after 2 days. And it's surprising. I'd be worried about waiting after an root ablation, for example, or an ablation.
Yeah.
And then the fourth point is that low-profile balloon have been very useful in your cases, especially in bifurcated case. In bifurcation case.
Yeah, let me reply to this
nice point. Yeah.
Last point. Your case was very nice with the right coronary artery, and I wanted to make the point that you have to rely on the balloons really well if you go for an intervention of very highly calcified lesion at the crux cordis with Judkins right guiding. So you are really confident that your balloons will work. So that's the point. What I was thinking watching your case, or the case in the previous presentation. So this is the same here. I'm quite sure that the balloons do a good job, but still I prefer to take guiding with a very high backup. So I think it can shorten the procedure time. So for the right coronary artery, I would still prefer Amplatz left guiding to Judkins right, but as we could see, it works either with low-profile balloons. So a very good thing. About the, I would like to comment on your third point that it could definitely be a little bit under some circumstances, it could be a little bit unsafe to wait for 2 days in a patient with untreated left main bifurcation. But he has been continuously monitored, and he got double antiplatelet therapy consisting of aspirin and ticagrelor. And so we were pretty sure that nothing will happen, and he was okay all the time. So, but there was definitely a valid reason not to do so, but we had to wait for these microcategories. And there's also one point, your toolbox should be complete, and it was not at that case, because we should have got this device in our toolbox, and we didn't.
Do you have also the supercross 90 degrees? Do you?
Yeah, now I have everything.
Now you have it, okay. Because in the first attempt, you could try to use the 90 degrees. The 120 is something you use it very rare and special cases. So maybe it's not, so to say, it's not very useful to have that in your cath lab, nor in a special case you have to order that. So it could be also helpful to use the 90 degrees in the first attempt.
Yeah.
And if I'm not mistaken, you have two other first points, the hemodynamical compromission and the EIBP. It was also a question of
if I would still use it one more time, yeah, if I would still take the Impella for this kind of procedure, yeah. Hard to say, I'm quite convinced that Impella is a very good and useful device, and I'm not really reluctant to use it if I see an indication for this, but it is quite astonishing to see that even in very long lesions, the pulsatile flow of the Impella is still maintained during orbital atherectomy. And I have quite extensive experience on rotational atherectomy in these very severely diseased patients with a bad ejection fraction. And I have seen for several times that the hemodynamics did really worsen under rotational atherectomy. It's sure, the shorter the run, the lower the risk that you will have some hemodynamic compromise. But according to some trials, the risk of having low flow or no flow is definitely lower in orbital atherectomy than it is in rotational atherectomy. And I would think about it, but I wouldn't say you don't need Impella for orbital atherectomy anymore. I still would think about it.
It's a nice point. So to underline that, you didn't mention any hemodynamical compromission of the curves, of the ABP, of the Impella curves during the atherectomy. It's a very important point because we are used to use Impella in such calcified cases with rotational atherectomy, and as you already said from the trials, the co-op PCI study, the results are very accordance with your experience, with your observations. Actually, we have less frequently mitral infarction in cases with with orbital atherectomy in comparison to rotational atherectomy. This is something that is in accordance with your observation, that you didn't have any hemodynamical compromission. What about the rhythmological also stability? Because the first case was a right coronary artery also in combination with the left main bifurcation. Did you mention during the right coronary artery atherectomy any rhythmological instability?
No, I did not.
You also haven't any pacemaker?
Yeah, but I, to be honest, I'm not a fan of RV pacing in rotational atherectomy either, so I haven't been doing it for 3 or 4 years. So I had a bad complication a few years ago that I had a pericardial effusion because of the perforation of the right ventricle. It was caused by RV lead, and then I read something in literature, and I figured out that it's not necessary or not crucial to have a pacemaker in rotational atherectomy, and now I try to keep the rotational atherectomy runs as short as possible. I give some atropine upfront before I start a run, and I see some mild bradycardia sometimes, but I normally don't see any AV blocks anymore. Nothing, not like in 5 years ago or 10 years ago, where you had asystole for 10 seconds sometimes. But if you do it properly, normally you shouldn't encounter problems like this, in my opinion. And if you don't need it for rotational atherectomy, you won't need it for orbital atherectomy either. So I think in most of the cases you won't need pacemaker during atherectomy. Never mind if it's rotational or orbital.
And the same question as prior. Why do you use or why do you choose orbital atherectomy in these 3 cases? You were also curious to use the system, or there are some special issues?
I think 2 of these 3 cases were during my certification. So at that time, basically, I was doing everything what could be treated by atherectomy with orbital. So that was the point. I think 1 or 2 cases could be even done with rotational atherectomy. Especially,
which one?
Especially this left main occlusion. The vessel
the first
was,
one.
yeah, the first one. The vessel was straight forward, and you could easily pass a rota wire over a microcatheter down the LAD and treat it very nicely without any problem with 1.5 burr or so. So it wouldn't be any problem to do so. The problem would be eventually with the circumflex atherectomy, because the angle at the bifurcation of the carina was quite acute. So I would possibly consider not doing rotational atherectomy to the circumflex, because the angle was not very preferable for this. And this and the other, the 77-year-old lady with this very tortuous LAD, I would definitely not choose rotational atherectomy for this patient, because the lesion was extremely long. Lesion was very calcified, and the ejection fraction was 25%. And I'm quite sure that we could have, or we could see some relevant overload of the vascular bed because of these particles, which are greater than in the case of orbital atherectomy, and then we could see really we could have some problems even with impella. So you could probably have some dangerous situation where the patient would rely only on impella support, and this is not what we are what we like, right?
Indeed. Last practical question: as you perform the orbital atherectomy in left main LAD and left main LCX, did you have an extra wire? So you have a wire, the Viper wire, in the atherectomy vessel. Did you have an extra wire, secure wire, in the other vessel? No. So only one wire. You had only the atherectomy wire, and the other vessel wasn't not secured. Okay.
There is also a nice tip or trick that you can perform your like this, or you can take a microcatheter and put a wire into a microcatheter. You can still perform your orbital atherectomy having security with your microcatheter and the other vessel. So it's also possible, but it was everything open. I had no concerns that something bad could happen there.
Okay. Christoph, thank you very much
for
the discussion also. So, Tommaso, we have, as I say, a new player in the game, very promising results from the first studies. We have the co-op PCI, not co-opt, but co-op PCI study, and we are just very curious about the results of the Eclipse trial with 2,000 patients randomized, the first randomized study in this field. So very promising situation. I hope we will gain some experience in this time, and let's see if this will make the change in the game. I think you can sum up and maintain the main points and enjoy the dinner after that.
So we have learned a lot of things today, even if the company was really intimate. And the first take-home message is that the CTO mindset is very important, and it arises from conferences like this one, from working in a place where CTOs are done, from educational program, educational training, from experts, and it's something that helps you in a routine practice, in a daily routine. Of course, you should have tools in your shelves, and you should have all the tools that are needed, all the devices, but you should know techniques and how to use your tools. It makes differences. It makes easier to succeed in difficult procedure, in difficult ordinary procedure. It makes safer every single procedure, and it allows to save time. And time is potentially, it is important because wasting time is potentially dangerous in our work. We have seen how to use this tool, starting from balloons and passing from the supporting left ventricle supporting device, but we have explored over mainly this new tool that this new debulking tool, the orbital atherectomy, sorry, that seems to be safer, and it seems very effective, and which main aim is to prepare a lesion, not to cross. We have seen how it is safe and quick, and we know that to set up all the system is easy, to use it is easy. We have a one-to-one response to our movement. We have maybe less need for PM. We have smaller particle compared to other debulking devices, and it makes safer, for example, in order not to have the slow flow or no flow. And if whether to use in very complex cases with low ejection fraction, whether to use or not left ventricle device supporting devices may be debatable, but this is a point that is crucial when one have to decide what kind of device to use. I think that the ease of use, the safety, and the effectiveness of this device make everyone more confident in using it. And this is the, let's say, the main take-home message I bring home.
Very well, so let's wait about the data from the different randomized studies, and let's see our practical experience in the Europe also to have a much more analyzed situation about this field. Thank you very much. Thank you very much for your patience, and enjoy the dinner.